Ultrasound is an effective imaging modality for bedside assessment of the lung. Lung ultrasound is unique from other types of diagnostic ultrasound. Typically, the purpose of ultrasound imaging is to visualize particular anatomical structures. The focus of lung ultrasound, however, is to interpret artifacts rather than visualize the lung itself. In this introduction to lung ultrasound, we will demonstrate how to answer the clinical questions of whether or not there is fluid in the thoracic cavity, air in the thoracic cavity, or fluid within the lung parenchyma. To assess for pleural effusion, use a low-frequency transducer. Place the transducer between the mid and posterior axillary line around the level of the 5th to 8th intercostal spaces. Use the liver or spleen as an acoustic window and angle the ultrasound beam toward the spine. Find the diaphragm moving with respirations in order to gain a point of reference. Adjust the depth to bring the vertebral bodies into view. In this image, the liver is seen caudal to the diaphragm, with a mirror image artifact of the liver seen cephalid to the diaphragm. This suggests a normal air-filled lung. Note that during inspiration, this mirror image artifact moves caudally and obscures the vertebral bodies. This artifact pattern is sometimes referred to as a curtain sign and suggests absence of a pleural effusion. When pleural effusion is present, there will be an anechoic wedge-shaped area above the diaphragm. This fluid-filled area acts as an acoustic window, providing an unobscured view of the vertebral bodies cephalid to the diaphragm. This is called the spine sign. Effusions can be large or small. When assessing for pneumothorax, the patient should be in the supine position so that air in the thoracic cavity will preferentially collect along the anterior chest wall. If the patient is not supine when examined, free air in the thoracic cavity will collect at the apical region and is more difficult to detect with ultrasound. While several probes can be used to assess for pneumothorax, the relevant artifacts are most easily visualized with a linear array transducer. In each hemithorax, place the probe in the midclavicular line with the transducer marker cephalid. Starting in the second intercostal space, evaluate each intercostal space down to below the nipple line. In this image, the soft tissue, ribs, and rib shadows serve as important landmarks. Below the ribs, the interface of the parietal pleura of the chest wall and the visceral pleura of the lung are seen as a single horizontal line, referred to as the pleural line. Note the shimmering comet tail artifacts that appear to move from side to side with respiration. This phenomenon is referred to as lung sliding and is only seen when the visceral pleura and the parietal pleura are opposed. It suggests the absence of pneumothorax with high sensitivity. Here, lung sliding and comet tail artifacts are not visible with respiration. The absence of lung sliding is seen not only in pneumothorax, but also in other clinical situations, such as lung adhesions or mainstem intubations, so it is a less specific finding. M-mode can be useful in detecting pneumothorax by plotting the movement of the soft tissue, parietal pleura, and tissues below. Here is an M-mode image of the normal lung. The top of the image represents the rather static chest wall and soft tissue. The bright line near the center is the pleural line, and the granular area below is a motion artifact produced by the lung sliding. This is referred to as the seashore sign. When pneumothorax is present, the motion artifact deep to the pleural line is not visible, and the image takes on the appearance of many horizontal lines. This is called the barcode sign. Once a region of absent lung sliding is seen, slide the probe laterally along the chest wall to check for the lung point sign. Visualization of the lung point sign is cited to be nearly 100% specific for pneumothorax. The goal is to visualize the point at which the area of pneumothorax is brought in and out of view during respiration. During exhalation, the lung falls away from the chest wall, and no lung sliding is seen. However, during inhalation, the lung expands enough that part of the parenchyma opposes the chest wall, and lung sliding is evident. Holding the transducer in the transverse plane in between the ribs while sliding laterally may facilitate the finding of lung point. Lung point can be visualized in M mode as well. Note the intermixed barcode sign and seashore sign. For the purposes of this exercise, we will use a low-frequency curvilinear probe. To assess for pulmonary edema, scan in each hemithorax in the midclavicular line with the transducer marker cephalid. Evaluate from the second intercostal space down to below the nipple line. When the transducer is perpendicular to the lung surface, a reverberation artifact of the pleural line gives the appearance of multiple horizontal lines equidistant to each other. These are referred to as A-lines, and this pattern can be seen in air-filled lung. When pulmonary edema is present, several vertical lines are seen streaming down from the pleural line to the bottom of the screen. These are called B-lines. Do not confuse B-lines with comet tail artifacts. While both are vertical artifacts that originate from the pleural line, B-lines have the appearance of searchlights or lasers. They should reach the bottom of the screen at depth settings over 12 centimeters. A diffuse bilateral B-line pattern in the absence of interstitial lung disease is highly suggestive for pulmonary edema. Note that B-lines can be seen in multiple types of lung pathology.